Hi, I'm Dr. Ralph Weiche. I am an emergency physician at St. Joseph Hospital, and I'm the supervising physician for our Bellingham medics. And today I wanted to talk a little bit about splinting for femur fractures. So this is an issue that has kind of come up from reviewing femur fractures, and what we found is that we don't do a very good job of splinting femur fractures. And so what I want to convey in this message is why we splint femur fractures and who are the patients we splint femur fractures, and to again to stress that there are a lot of fractures that you can splint in a position of comfort, but a femur fracture is not one of those, and we'll explain why that is. Of course, one of the first parts of splitting a femur fracture is being able to identify that. And I've heard from some of the medics that it's not always clear as to whether it's a femur fracture and whether it should be splinted. Is this a pelvic fracture? Is it a hip fracture? Or is it a femur fracture? So I just want to show you the quick little assessment that I do that helps me decide whether I've got a femur fracture or a pelvic fracture. So typically, when you have a femur fracture, it's going to be a mid-shaft femur fracture. Most of the time, in your typical mechanism for a femur fracture, when the femur is under stress, it's going to snap right in the middle. And so you're more likely to have a mid-level or a mid-shaft femur fracture. So if you have a femur fracture, you're gonna be able to tell that where the pain and the swelling is in the mid-femur. So if you palpate the mid-femur, it's going to feel swollen, it's going to be painful, it's going to feel tense. You're going to feel those muscles that are already starting to spasm and tighten up. And if they're able to communicate with you, that's where they'll identify most of their pain. Whereas in a hip fracture, they may have pain from a hip fracture in two different areas. The most common is it's kind of more in the groin or the inguinal area when it's a femoral neck fracture, so they'll complain of pain there. Or you can have an intertrochanteric fracture where maybe the pain is a little bit out more lateral along that bony prominence on the side. And one way that you can distinguish that is just you palpate the thigh to decide whether you feel like it's in the femur or not. And then if you just simply roll the leg back and forth like this, typically that is going to elicit the pain that the patient is going to be able to better localize. So if you roll this back and forth, they're going to tell you their pain is now in the inguinal area. That's a hip fracture. If you rotate it back and forth, and that's not where the pain is more in the middle of the femur, then that's a femur fracture. Okay, so I'm going to talk about what are the reasons why we want to put a femur fracture in a traction splint, and why is that particularly true for femur fractures? There's maybe three main reasons. One is because it is such a large bone that's so well muscularized that when you have that fracture, the muscles are going to spasm. It's going to pull the bones and they're going to rub across each other, and that's going to increase your pain. Remember, the bone is covered with a periosteum, that covering around the bone, much like the bark on a stick. And it's that periosteum that is innervated. So if the muscles spasm and it is pulling that periosteum of the bone, that is exquisitely painful, and that is where a lot of the pain comes from. So if you can put somebody in a traction splint and pull those bone edges off so that they're not rubbing and they're stabilized, that's going to go a long ways towards pain control. It may be painful initially as you're straightening that out, and their pain needs to be managed in anticipation of that, but once you get them out, it's going to be much less painful, and they're going to be much more comfortable during the transport, because it's inevitable that those muscles are going to spasm, but now the bone is more stable and their pain is going to be easier to control. So pain control is one of the reasons. Another reason is the proximity of the vessels, of the arteries to the femur, are such that when you have a broken femur, you're much more likely to pinch off that artery and to lead to ischemia to that leg. So we know that the longer the leg is ischemic, the less likely you are to salvage that limb. So that if you're able to reperfuse that in less than an hour, you're going to save greater than 90% of those legs. But if they remain ischemic, your odds of losing that limb increase. So ischemia is another reason. Getting that bone out the length will straighten out that artery, will improve the perfusion. So the third reason why it's important to place a femur fracture in a traction splint is related to the amount of blood loss that can happen in a femur fracture. So not only can you have bleeding from a vascular injury, you also have bleeding from the muscle tissue injury as well as bleeding from the bone. When you bleed into that thigh, you can lose up to 1.5 liters of blood, and even twice that if it's an open fracture. So what we're trying to do by putting somebody in a traction splint is that potential space in the thigh is more spherical, it's more round, and this shape holds a much greater volume than what a cylinder would hold. So what we're trying to do with our traction splint, if we're trying to lengthen out the thigh and we're trying to change this potential space from a sphere like a basketball to something more cylindrical like a football. The volume of a basketball is related to the cube of the radius. The volume of a cylinder is related to the square of the radius. The reason why that's important is that, say if you've got a 6-inch radius thigh, you're multiplying that by 216 to get the volume, whereas if you're doing a cylinder, you're multiplying it by 36 to get that volume. So that's just an indication to tell you that you're talking about a considerably more volume that you could potentially bleed into, that much more blood loss if you're bleeding into a sphere versus where you're bleeding into a cylindrical object. So by placing a traction splint, you're lengthening out that thigh and you're changing that potential space from a sphere to a cylinder, greatly reducing the potential space that somebody can bleed into, and that can make the difference as to whether somebody sanguinates into their thigh or not.